Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce you now. Dr. Charles Meakin is a 63-year-old physician who works to integrate metabolic health strategies into cancer care. After graduating from the University of Notre Dame with a degree in economics and pre-medicine, he matriculated at the University of Cincinnati Medical College. After completing his residency in radiation oncology at Stanford University Hospital, he supplemented his formal education by enrolling in a diverse array of programs, ranging from hypnosis and nutrition to Eastern philosophy. As the former chief officer of care oncology, Dr. Meakin strove to introduce effective, well-tolerated holistic adjuvants to supplement the standard of care and measure their impact on patient outcomes. He continues that quest today in his own clinic, meakinmetabolicare.com. Interventions examined include simple balance training programs, diet adjustments, supplements, repurposing of metabolically acting drugs, portable O2, exercise bands, and sleep hacks. When he is not doing a virtual consultation, he enjoys spending time in nature. He and his wife, Lindsay, love to hike the North Carolina mountain trails near their home and cruise stand-up paddleboards on nearby lakes and rivers. Dr. Charles Meakin, what an absolute honor it is to welcome you to Boundless Body Radio.
Hey, thank you, Casey. It's awful nice of you, and thank you for that introduction. And I have to confess, the clock has turned. I'm now 64, so heading toward, I guess, free healthcare or lower cost healthcare.
There you go. There you go. Well, you look amazing at age 64, and I'm doing a terrible job of something here on this podcast. I've been really actively trying to dissuade people from knowing anything about Utah. I don't want anybody to know anything about Utah. I want them to move to Colorado or go to California. And just yesterday, I had a listener of the program reach out to me on Instagram and say, like, hey, I'm thinking about like moving to Utah. What area should I check out? And I was like, no, damn it. That's out of the bag. It's such a wonderful place around here, and you visited recently. Tell us about the trip that you took out to Utah.
Yeah, so I've always wanted to come out there, and one of the kids that was in entrepreneurial school with me, I went back after sort of working in healthcare. Travis lives out in Salt Lake City, and he is a true outdoorsman. And so myself and another local hiker who's done a lot of mountaineering. We've done, mild mountains. We've done like Kilimanjaro and Mount Whitney and sort of the Olympic range, Mount Rainier, Adams, Baker, those kind of things that are more technical. But then we wanted to just come out. It was kind of, at the latter part of the pandemic, and we did 7 days and 4 places. Red Rock outside of Las Vegas, Bryce Canyon. We went to the north rim of the Grand Canyon, and then we went to we did the Narrows there. And
so it depends on whether you're a local to Utah or not. If you're local to Utah, it's Zion. If it's
Zion,
yeah. If it's everywhere else, it's Zion.
Zion, yeah. And that famous climb was it's called Angel's Landing, where it's kind of dangerous. We have to hold on to a cable. Well, that was closed because of the pandemic. And, they said didn't want people getting too close to each other. Yet people were sort of pirating it and getting on it. But, as a physician with 45 licenses, and I was like, I can't get hot for something like this. So I said, no, we're just going to do another trail.
Nice. It's pretty dicey up there, man. It gets very steep, and there's like chains you have to like climb up, like you said. Like, yeah, it's pretty dicey. But Utah's an amazing place.
It is. It is.
But so is North Carolina. I got to visit there a few years ago, and it's absolutely amazing there too. Very beautiful.
Yeah, we have a lot of that, and like 2 Saturdays ago, I went to our local mountain, and there's rock climbing there and good hiking and whatnot, and a lot of good lakes and rivers. Whitewater kayaking is big here. Charlotte has the U.S. National Whitewater Center. I was on the startup board for it, and it's got class 3 and 4, runs, man-made. It's on a river. We got climbing, mountain biking. It's on 1,000 acres. It's a real dream for outdoorsmen.
Yeah,
and women.
That's fantastic. If you can stand the heat in the summertime. And you mentioned paddleboarding, which is one of my favorite things to do. We've got a lake just a mile away, so I take my paddleboard up there
Mhm.
all the time. And one day, a buddy of mine and I had the idea to try rivers. It sounds like you are paddling rivers and lakes there. But the river we chose was like kind of a mountain river, and it was like the end of the season. So there's less
Mhm.
water, but it was still rushing really quick. And so immediately as we put our paddleboard in and jumped on, we were going like 5 miles an hour. And I can tell you, when you're going 5 miles an hour, but your paddleboard stops because it hits a rock, you continue moving
Oh
at
yeah.
five
Oh
miles
yeah.
an hour.
You face plant.
Oh, it was not great. It was not a good idea.
I actually have paddle boards that are somewhat designed for like running rapids. Now at the Whitewater Park, kids do that, but you're gonna have some aggressive falls. I just do, whitewater kayaking there, and now I have taken, my board on slow rivers, just for sightseeing.
Yeah,
Um,
I'll keep it on flat river, flat water.
yeah.
Oh, that's amazing. Well, you have such an interesting story getting into, um, a kind of different way of looking at oncology. Very near and dear to my heart. I lost my mom to cancer,
Oh
and
my
I
goodness.
very much believe that it was the treatments that killed her, not necessarily the cancer. But regardless, we're learning so much about cancer, yet we don't ever really seem to be moving the needle as far as the people that are being diagnosed, how many people are dying. Like it seems like there's kind of a disconnect as to like we learned so much about it in all this genome project, and that didn't really lead to anything. It's like, are we making any progress?
Well, I can see how one would feel that, well before your time, Casey. 1971, I think it was, Richard Nixon declared the war on cancer. And, he said, we're going to spend money on this. And, in 5 years, we're going to figure this out. Well, that was what, 50 plus years ago. And, cancer is just under heart disease is the second most common cause of death in America. However, it's more and more a cause of life disruption. We now have 14 cancers that are on the rise that are more so metabolically driven. Historically, we had worries about smoking and smoking related cancers. Those are actually slightly on the decline. And now we're seeing these metabolically driven cancers, which are common sites like, ovary, breast, pancreas, endometrial, colorectal. Colorectal's really, spiking in younger people. I see a lot of people, and historically, if I saw somebody in their 20s or 30s with colorectal cancer, it would be sort of something to write up in a journal. But now we're seeing a lot more of that. And I don't want to, pull the alarm bell, but, only about 25 to 30% of cancers diagnosed are diagnosed based on routine screening. Meaning, if you did everything to the letter, that we know to do, that's recommended by NCI, the American Cancer Society, you would only find about 25 to 30% of the cancers that develop, in the United States. So that leaves a big gap of like, how are we going to find those ones that are not being found on routine screening? So the good news is there's some blood biopsies coming out that look promising. One that I'm excited about. Secondly, there are ways to, modify your 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 health and wellness well before you are at that risk stage to get cancer. And that's a big part of what I do at Meakin Metabolic Care. I do a onboarding inventory, look at risk factors, and not just say, well, based on the screening, you don't have cancer. We say, hey, you got some small smoke signals here that need to be managed so that 10 years from now, you're not going to be at risk for cancer. So that's kind of a big part of what we do. And I can talk more about that if you want.
Yeah, no, absolutely. And it's cool to know that you're working with Travis Christopherson. We've interviewed him a few times. We've interviewed Dr. Seyfried a few times, Braddock and Maggie Jones, who I get to
Oh
see on your
yeah.
website. Working with Maggie is very cool. So we've learned quite a bit about cancer. And I don't think we've done a good enough job talking about the history of cancer itself. And I think you would be an awesome person to talk to. I've heard you talk about this in the past. I don't know how far back you want to go. Was cancer something we always got as a species, do you know? Or like, can you take it through
Yeah,
kind of like the history of
it,
cancer?
it's it has been with us a long time. I mean, going back to mummies, Egyptian mummies buried, but a junction point that's kind of interesting for our today's discussion is, the German society we're seeing, because they're one of the early industrialist societies, we're seeing a rise in cancer. And in the 1930s, there was a sort of mandate to sort of try to investigate more resources to figure out cancer. And one of the early, researchers over there, physiology researcher, Otto Warburg, who interestingly, was use what we consider today some of primitive, research tools, but identified a paradox that cancer cells would burn glucose in the presence of oxygen. So they had this, non-aerobic metabolism, the mitochondria of those cancer cells, despite having availability of oxygen. And that, was very inefficient. When you are at peak running, you have to start, because you're not getting enough oxygen, to fulfill the needs of the muscles. You have to start making, ATP through the burning of glucose in an anaerobic, non-oxygen way. And you only make, for every glucose molecule, you only make 2 ATP. So it's really, sloppy expenditure. Well, cancer cells do that all the time. And normally when we use oxygen, we make 36 ATP from one glucose molecule. So that was a point where he, first of all, won a Nobel Prize for it in the 30s. And he was looked at his cancers, opportunity for targeting was this metabolic variants. And then with Watson and Crick and the invention or the study and finding of the DNA, coil and whatnot, shifted to more of a targeting of, genetic mutations as the cause of cancer. And that's called the somatic mutation theory. And then the metabolic theory, namely that, cells that ultimately lose their ability to create efficient energy then lose the sanctity or the control mechanisms that control transcription in a sound way. And there's a whole big story around Otto Warburg that's pretty interesting. He somehow was given privilege by Hitler to continue his research, even though he was a Jewish researcher,
Yeah.
in Germany during World War II. So ultimately, he was, his voice wasn't heard too much after that, even into the 50s. And then this somatic mutation theory caught hold, and all our energies have been at genetic targets until probably the last 15 years, through thoughtful people like who you mentioned, Travis Christofferson's book, Tripping Over the Truth, started saying, we're missing something here. And by the way, when you do a PET scan, the reason it works is you take a glucose molecule and you put a radioisotope on it, and it works because it goes right to the tumor. And that's, separates, normal tissue from tumor cells. Now, granted, there is a lot of uptake of glucose in the brain and in metabolically active areas of the body, like the heart, and it's created through the kidneys. So those have some highlighting, but really the differentiating quality there is the appetite for glucose. Now, more recently, the work of different researchers like Dr. Cantley at Cornell University in New York started, finding targets like P13K inhibitors that work on the transporter that pulls glucose into cells. And now the theory is more of a probable blended theory that it's metabolic and genetic instability. And so what we do is use repurposed drugs and, other sort of easy lifestyle interventions, maybe supplements too, that make it harder for cancer cells to acquire glucose, use glucose, be upregulated to use glucose, as well as doesn't, impair normal cells as much. In fact, sometimes some of our interventions are beneficial to our normal cell population. So it's been exciting for me to find such an easy solution to problems that have like, I'm 35 years into treating cancer patients, finished at Stanford in 1989. So, I'm now seeing the first long-term survivors, there maybe one or two in the past 30 years, but in the last 5 years with glioblastomas. Not everyone, mind you. I don't want to call that out, but until we used a blend of sort of low carbohydrate eating, ketogenic or modified ketogenic type diet, repurposed drugs that, stress metabolism of cancer cells, mainly glucose and glutamine and amino acid. And thirdly, some standard of care, not everybody doing all standard of care. I've now seen people that are out 3 and 4 plus years, where I didn't see that before.
Yeah, that's amazing. One of my favorite parts on the show was talking to Travis about ketones themselves and how they're, you know, beneficial to the body, but also can help with cancer. And reflecting that, like, you always have trade-offs in medicine. It's always like you take this and it helps with this, but then you have these side effects. It's so rare that you have something that is bad for the cancer, but also good for all those other tissues, like you
Yeah.
said. And we always have to say that this is, when we're talking about metabolic therapies in particular, we're talking about adjuncts to some standard of care, whether that's the whole package of what people are getting, chemo, radiation, surgery, debulking, whatever, or whatever they're choosing. We have to say that these are adjuncts. This is not the cure for all those things. It doesn't replace standard cancer treatment, but we do have case studies. We have Pablo Kelly, who we interviewed a few months ago. He
Yeah.
is alive 9.5 years later. He did nothing besides go, mostly low carb carnivore. So can it be done? Like, it looks like it can be done. People are doing it. We have studies, case studies.
Yeah. Well, especially in some of these disease sites where, like, I see people all the time, and one was most recently sort of it wasn't a full glioblastoma. It was kind of a grade two and a grade two glioma, and they had had surgery, and of course, it wasn't. You can't ever get good margins on the brain, and they were told, well, you need to do chemotherapy now plus radiation, and this is a young 35-year-old person, and I said, well, you want to use, you got a few tools in the toolbox. There's nothing that says doing that right away is going to be, absolutely necessary. Let's just watch it and do metabolic therapies. And if you go 3 to 5 years before something shows up, that leaves more time for a novel therapy to drop out of the research sphere. Secondly, that's 3 to 5 years where you're not dealing with the side effects of, you know, post-op radiation and PCV chemotherapy in this individual. And so, that was a little bit of basically, I just planted that seed to discuss with their doctor. And that's what they did. And they're, still watching it. They're on, low carb eating, metabolic therapies, optimization of their, when we see people, I kind of go through an onboarding and score everything in a simple below average, average, or above average, 1 to 3. And I call it the metabolic optimization protocol score calculator. But we ask them about sleep, nutrition, their breathing status. In fact, with glioma, there's a small study where people who just exercise parasympathetic, promoting nostril breathing had an improvement in their, median survival. But also things that, like hydration, using it as a great tool for getting rid of the byproducts of metabolism and re-electrolyting your body in a good way. Their stress patterns, their sort of goal-oriented mission alignment. Then also body measures like their BMI, their your waist to height ratio. That's a predictor of longevity. Granted, there are certain cultural populations that are might not fit into that projection, that model quite well. Like maybe Alaskan natives or tend to be wider and shorter, and they probably wouldn't have that same ratio prediction. We also look at like the 1 minute push-up test, their fatigue scale. And then from a laboratory standpoint, we kind of run the gamut here. We start with measures of inflammation, looking at high sensitivity C-reactive protein, ferritin level. We also look at their detoxification efficiency by the GGT level. We look at their metabolic profile, looking at hemoglobin A1C, their calculation called the HOMO IR, which really looks much further ahead. I mean, I see a lot of people that look okay on the hemoglobin A1C, but they have insulin resistance on the HOMO IR,
Okay.
just because it looks more in a more sensitive way. We calculate something called the Feldman ratio on their lipids. We look at their efficiency of methylation by the homocysteine level. We check their thyroid. Like today, on a patient this morning who has recurrent prostate cancer, ironically, he was starting to fail in his thyroid. Now, he had a lot of inflammation from poor lifestyle choices. So I said, let's fix that and see if your thyroid doesn't just correct before we encourage you to get on Synthroid and be on it the rest of your life. We look at kidney function, liver function, bone marrow function. Uric acid is a measure of fructose metabolism and other measures, vitamin D level. And we also look at morning cortisol and some, basic electrolytes like magnesium and stuff. So we do that, put it in a calculator, find the variances, kind of narrow it down to the big 3 to 5 variances, and then focus on those which have lifestyle interventions like resistance training or modified keto diet with some intermittent fasting, things like that. We use some core supplements, mainly vitamin D3 with K2, omega-3 fish oils on a base low level for most people, like 2,000 a day. We have some other, for cancer patients, we're a little more aggressive at suggesting medium dose melatonin. It has some good data to say it reduces ROS, especially in the area of the brain, oxidative stress in the brain. We also, for more prevention patients, we use like an old drug, glucosamine sulfate. They find that kind of works like metformin. And there are 3 big studies showing improvement in all-cause mortality, which is kind of a sleeper thing. People use that for joint health, mainly in the 80s and 90s, and up till recently. I'm excited about some other drugs that are more pharmaceutical, but in low dose, like metformin, torvastatin, one of the statins. And then we're looking ahead to consider even sirolimus, which is Rapamune. There's some great data with that. It's in low dose, it's safe. And the price has recently come down to make using it once a week for longevity work even now affordable. It used to be somewhat hard to afford, but it's generic and the price has recently come down.
Interesting. Wow. So many different tools that you can use. I love how comprehensive that list was, but it was also very practical and pragmatic. You can narrow it down by what are the biggest things that you're willing to work with. And I'm sure every patient is going to be a little bit different as far as what they are willing to do about their treatment.
Mm-hmm.
But let's just say you give me the diagnosis today. I decide that I don't want to do any of the standard of care. I don't want radiation. I don't want chemotherapy. I don't want surgery. In your opinion, of all the tools you have, if I could choose one, in your opinion, what do you think would be the number one thing you'd want me to walk out of your office thinking like, okay, I can do this one thing, I'm going to nail it? What do you think would be the best chance? I know that's a very general question.
That's a tough one. But if you had active cancer, sometimes I go to great lengths. If I see low-hanging fruit, and I tell people, I've been on this side of the fence and on this side of the fence, and I try to use the best of both. Like I had a lady last week who had, stage 2 breast cancer, and she wanted to do, just alternative therapies. And she was already kind of progressing, doing a lot of supplements before she met me. And I tried to convince her to have a stop date, to say, hey, this is still probably in the curative zone. I'm not going to say that any surgery is minor, but if she had to have a lumpectomy and actually dissection, that's not a bad thing she was a young lady, to sort of get a confidence that this is out of your body, and then we'll do as much as we can she might need to use some standard of care after that as well, but do as much as we can to enhance the outcome And if she does do, say, radiation to the chest wall and breast, then we can mitigate that with some pre-radiation, slightly modified fasting, not like 3-day fasting, but fasting from midday the day before with, some ketone enhancement right before the radiation, which greatly mitigates the normal tissue side effects and makes the cancer cells actually more vulnerable. So I think if it was one thing, it would probably be, you know, uh, management of insulin insensitivity or insulin resistance to get people eating low carbohydrate, to get people having some blend of intermittent fasting, get people, as long as they're not cachectic or really low on their weight level, get people to do some version of exercising after their meals to mitigate that spike in blood sugar. And I think that would be the biggest thing they could do. And that generally in itself, slows down cancer cell metabolism, because, if your insulin levels are riding at the guy I saw today, he had a hemoglobin A1C of 5.7. So that doesn't look, it's not great, but it's not terrible. And he was off everybody's radar screen as having any sort of diabetic or prediabetes, but he had an insulin level of 20. So insulin is an anabolic hormone. It tells cells to, you know, it, 99% of our existence, we ate every 24 to 36, 48 hours. So insulin was a survival benefit. When we had food on board, it would tell our cells to make new cells because we had to replace those old ones. It would tell cells to grow through mTOR. Number two, it would turn off fat burning because we now have substrate available. We want to save that remaining resource for a rainy day. And it would also turn on, storage of like fats and sugars for future use. So that all was good until we started, having snacks and high sugar, like carbohydrate snacks every 2 to 4 hours. So now we're sort of like, a polar bear trying to live in the desert. We're out in, hot Utah. It just is incompatible. And that's why we're seeing those 14 metabolically driven cancers. That's why we're seeing all the itises that we see in people today. And the beauty is when you start cleaning that up, all those itises, the sinusitis, the plantar fasciitis, the dermatitis, the chronic pulmonitis, all those things that people go to see individual doctors for, they start clearing up because you're not, in medical terms, pissing off your body, So,
Yeah.
um, it's kind of neat to see that when you get someone who buys in.
Yeah, that's amazing. I agree. I kind of went there in my mind as well. Like I've been carnivore for 4.5 years, so I'm not too concerned with a lot of this stuff. I'm already eating a very low amount of carbohydrates. But the day I get a diagnosis, that would be the last day I would even look at any of the stuff. I would try to, incorporate more fasting and that kind of thing, maybe be even a little bit more strict than I am today. And I'd feel pretty good about that, knowing what I know now. But the patience thing, I think is really interesting too, because, to send that person away and say, look, let's try this. Let's have a date that we reanalyze and reevaluate, and we can always do other things. We can do chemotherapy, we can do radiation, we can do surgery. That's all still on the table, but this isn't going to kill you today. Why not just try this? And at the very least, you hear stories all the time of like the tumor shrunk a little bit, so it was easier to debulk, and now it got out, and now it's like, okay, I don't even know if we need chemotherapy or radiation. You might avoid that entire rigmarole.
Yeah, yeah. So also too, if they downstage it and the pathologic findings after some surgery look more favorable, then that's not a bad thing. And you know, like let's see, was it yesterday? I saw a prostate cancer patient who actually was diagnosed in 2016, and now he's starting to fail again. He was from the Northeast, from Massachusetts, and his PSA is starting to repop. And ironically, it's kind of funny how this worked out. But he was told by like his urologist, if he doesn't jump in, he had a positive lymph node on a PSMA PET scan that he's probably going to only have a few years. Well, you know, that is there's a delicate way to handle this stuff. If you see someone like walking away from like a really easy fix, that's, I think it's reasonable to try to remind them that you got an opportunity here. Let's have a system in place so we don't, walk away and turn our backs on something that's highly fixable. But you don't want to, bury people with a what I call a nocebo effect, putting the fear in them that something terrible is going to happen, because we can manifest that. It's like the placebo effect. You can sort of almost curse people by planting negative, thoughts in their head. Unfortunately, he was able to sort of like shake it off. But as I said, he was back in 2016, and now I just thought of this as we were talking. He lives in Massachusetts, and he recently had a rash that he couldn't explain, and he got it evaluated, and his PSA had crept up to like 6 to 7, and he was about 2 weeks. He had used doxycycline for Lyme's disease, and that's one of our repurposed drugs. And his PSA had already dropped to like 3.4. Now, that was a pretty quick change. Sometimes you can have get 10 to 15% difference in PSA, especially if you measure at the same lab. If you go to different labs, it could be a little different. But a 15% drop, a few weeks into using this, you know, inexpensive, low-cost antibiotic for Lyme's disease, and that's one of our primary repurposed drugs we use for, in the care of cancer patients. And it's not crazy science. I mean, there's a big university in England who's taken doxycycline and slightly changed the molecule, and they call it doxysar, and they're taking it to a clinical trial path to try to get a new drug indication. If it's a new molecule, you can cash in again on it, and call it your drug. In another one of our repurposed drugs, mebendazole, which is an anti-parasite drug, Johns Hopkins is also doing that with a venture capital company. They've changed it slightly after doing a lot of research on brain tumors and pancreatic cancer. So a lot of these drugs may sound crazy to the local regional oncologist, but there's a lot of behind the scenes activities that if you dive into it, you'll realize that these are safe, easy things to use. And especially in a cocktail effect, they impact cancer along with standard of care. And, if you think back, and we were talking about the history of cancer, leukemia used to uniformly, and lymphoma used to uniformly kill everybody. When they started using multiple drugs all at once up front, instead of waiting for resistance to develop, they kind of preempted it by using different acting drugs all at once. They started getting cure rates. Leukemia, like adult leukemia, about 50% of people are now cured of it. Pediatric leukemia is much higher. The Hodgkin's and non-Hodgkin's lymphoma, even AIDS is when they use multi-drug therapy, and TB up front. Is that when they started fixing it? If you think about mathematical models, if you do, a lot of the time standard of care is treat with this combination. When you fail, jump in with plan B and then plan C, and then you pretty much run out of options. But our strategy is to use as many effective, therapies that are tolerable up front, and like repurposed drugs, lifestyle interventions, supplements that have utility used up front, right with the standard of care, if that's available and that's possible. That's when you have the best chance of fixing these things. And that's what we're seeing in the clinic.
Yeah, okay, that's amazing. You said something very interesting that I'd like to dig into a little bit. With the drugs, you mentioned the older drug and being able to cash in on the drug as you repurpose it, you change it slightly. Now it's a new drug. And so the drug company can then make money. I believe it's 15 years. Don't they have a patent for 15 years before a medication becomes genetic?
Yeah, it depends. If
Generic.
it's in orphan use, it might be a little bit longer. It's usually like 7 years, and it starts when, it doesn't start when they do the research, but usually it's about 7 years after they get the research done. And as you know, I don't want to pick on the system, but they say about 80% of the drugs that get FDA approval now are not really new novel interventions. There's sort of slight tinkering of older patented drugs right as they're about to come off patent, and then they make it a long extended use drug instead of a 3 time a day use drug, or they modify it simply to kind of add something to it to prolong that patent. So we're not seeing a lot of new stuff come up, and that, of course, because of how much money they spend, the FDA grants them the permission to charge, to regain their investment. So that's why, there's been no new cancer drugs in the last few years that aren't, less than $30,000 a month. I mean, everything's out of control.
Yeah. So that's what I'm wondering. Like, if these generic drugs are not being used and prescribed because nobody's really kind of studying them because they're off patent, so the drug company is not motivated necessarily to
Correct.
continue learning different things about it. Would repurposing a drug and then remarketing it actually be a good thing, even if it does cost $100,000 a year or $1,000 a week, whatever the number is? Would that be almost like better that at least it's getting attention and getting into people's hands who can afford it or have the insurance?
Well, it might be, say, if they repurpose the new version of mebendazole in the next 5 to 8 years, it's going to have a big price tag. But then, like sort of the army of oncologists that work in big hospitals that kind of follow the menu of sort of NCCN guidelines and sort of best practices and all that stuff, it will probably get on their option list, and it might be utilized. Yes, again, it doesn't fix healthcare because healthcare is out of control, expensive. And if you've had any interventions in the last few years, you realize it's hard to get surprised anymore. Things are crazy. But so the question for me would be is, would like standard mebendazole still be around to use? Now, mebendazole is a unique case because a company, it was dirt cheap, it was out of patent. Company picked it up for a lower price and then did a very small study on pinworm in kids, very quick, short study, and got their own new indication because it wasn't sort of approved for pinworm. And now it's, was under a name, I think, Vermis, and the company, made it $400 a pill. So to get it to patients, that would be affordable. In Canada, it's like $6 a pill.
Wow.
That's still expensive, for 30 days and doubling the doses. So we work with some pharmacies that import it from overseas. They have like an intermediary, and then they validate its pharmaceutical grade by independent consumer lab testing company. Pharmaceutical grade means, low attenuants and the potency that is intended, and then they get it to these pharmacies and they put it into capsules, and we get it to patients at a reasonable price. It used to be a little better. Now I think they had to switch providers for mebendazole, so it got a little higher. But in general, a normal 1 month package, I'm told by the patients, it's usually of like 4 to 5 drugs, is usually in the range of like $80 to $100. Um, and most of that is mebendazole if mebendazole is involved. So because of the compounding factor, metformin, atorvastatin, doxycycline, all those are very inexpensive.
Yeah, interesting. Okay, you just always hear that like that will never happen. It'll never be mainstream because people don't make money on really inexpensive generic drugs. And you mentioned a few there. I know those are kind of the core four that you like to use.
Mhm.
I would really prefer that somebody live a healthy life from an adolescent into adulthood and don't ever need medications. That would be my preference. That said, there is a place for medications for people that need them when they need them. And metformin for me seems to be one that is pretty maximally beneficial with not a lot of like downsides as far as I understand. Would you agree?
Yeah, so it's interesting. I was probably like you, Casey. I was an avid medication non-user. Fix it with lifestyle changes and how you eat and live and sleep and whatnot. And I wasn't a total choir boy. I worked hard, worked late. I did a lot of sports that were a little bit dangerous too. Mountaineering, whitewater kayaking, and that kind of stuff. And but about the probably through working with Travis and Care Oncology and sort of looking at this back data, and I was like, well, you know, I was very dismissive of the data with statins because when it first came out, I don't know if you remember the Time magazine. One of the beauties of like studying economics and understanding statistics and math is I always kind of looked at the value of this to an individual, and I would always try to organize things into NNTs, number needed to treat. How many people, if I treat with this, will it benefit? Because I have my own little sense of if I'm going to get benefit 1 out of 50, and it means preventing a recurrence, that's sort of like an airplane in the wind. That's a very low probability. Now, when the Time magazine came out, they said, like 34% reduction in cardiovascular events or death from cardiac events. That sounds really powerful. 1 out of 3, 35%. But that was a relative risk reduction. That compared those who got the placebo versus those who didn't, who got the drug. And really it helped somewhere between, if you looked at the error bars, it helped as many as like 1 out of 35 to as 1 out of 130, and so that was in the zone of walk away from that. But it was only at like a 5-year juncture. And there's an expert in lipids, Dr. Snyderman, who has kind of looked at it. He's a big advocate of looking at ApoB more as a marker than LDL or other markers. And if you look at the 30-year return, the NNT really improves, mainly because we're all going to get, never say never, never say always, but most of us are going to get some sort of blood vessel disease that's going to affect the brain or the heart or distal extremities. And that number needed to treat drops to 1 out of 7 at 30 years. So to me, that starts to get pretty relevant. If I can knock out vascular disease, and it's not going to be all or none, but the death from cardiovascular event, improves 1 out of 7 at 30 years, probably is helping a lot of people's blood vessels in a less than causing death way. That becomes a better consideration. And then you can, follow markers and look at it that way. Like I just had a talk with my son who's just hit 30, and he's, a bit of a modified ketogenic guy. He lives really clean, but he had a high ApoB, and I said, we might want to consider some early statin use for yourself. Now, metformin, we're all waiting for the TAME trial where they took healthy people and they put them on either placebo or metformin, because the original studies, were people with, presumed diabetes showing a marked improvement, and kind of the reanalysis of that is, there's some questions around it. But for me, you're right. It's cheap. It's invisible to, I don't notice I have any side effects from it. I take now a low dose statin and metformin routinely for prevention of disease. I think the two have some synergy together. I kind of go back to this trial from Taiwan where they found, hepatitis is very common in the Orient and Asia. And hepatitis is a viral infection that elevates your risk of many cancers, especially liver cancer. And they had 70,000 people that were Hep positive. And they looked at this big data set because everybody's on a national healthcare system there. And it turned out that, a big block of people were on atorvastatin or a statin, a big block of people were on metformin, but they had 5,000 people total that were on both. And if you happen to be on both of them, now granted, population studies aren't perfect, but if you happen to be on both of them, your rate of the like 10 most common cancers went down dramatically. And so that was pretty relevant. I mean, the lowest amount it went down was like 28% compared to people not on both of them. And if you're on one of them, it helped modestly. But if you're on both of them, it was a powerful effect. And
Wow.
so So it's sort of the bet I'm hedging, kind of figured this out. As you said earlier, they're not going to do clinical trials on this. They're doing a trial for metformin. And, and then once again, there's some trials out there for, as I mentioned earlier, on this other, you know, drug that's out there called sirolimus or rapamune. And that looks very promising. Uh, there's a molecular uh, testing organization. I believe it's called ITP, and it's 3 labs around the country that have best practices. They use the most, you know, lab animals for testing can get so inbred that it doesn't really reflect normal biology that might reflect what might happen in a human. But they use sort of the least inbred version of the lab mice. There's whole science behind that, and they test molecules. And they've tested resveratrol, they've tested metformin, they've tested NADH, they've tested the 17 estradiol, and rapamune. And rapamune had some of the best results. They actually tested it in the chow daily, and one of the most relevant things about it was they had some problem getting it in the chow, and making sure it didn't get broken down in the acidy digestion process. So the mice got older, and they're like, oh, we maybe don't even want to test them, because you know we don't usually start with mice that are already 3/4 of their normal age range. But they did it anyway. They found that there was still like a 35% improvement in survival, even though the mice were like 3/4 of their normal age. So kind of extrapolate that to a human, which is always a little bit dangerous. For like a 60-year-old fella or a woman, it might be beneficial. Usually we think, well, the die is already cast. You should have started at 40 or 30. But, that looks impressive that you could start that late in life and have some impact. So more to, the story's yet to be told there, but a lot of excitement around that.
Interesting. Okay. You're kind of blowing my mind on something that I don't think I've ever like really considered. So I'm so excited to ask you about this. The statin thing. This comes up on our show all the time. A very prominent cardiologist. I don't need to use a name, but and I know, and everybody listening probably knows who he is. He's a longevity expert. He's written an amazing book about longevity, and everybody in the low carb space is like, okay, I'm on board with 95% of everything this guy's saying, but he's still saying that he's very pro statin for some people. And we have this cohort of people in the low carbohydrate space. It's not many, but it is some, that if they have a low enough BMI and they go low enough carbohydrate, their LDL cholesterol goes really, really high through the roof. Thus, their ApoB is also going to be very high through the roof. And so it's this kind of push and pull of like saying like, okay, I thought the number needed to treat was 229 with a statin, but I had never considered the longer you use it, the better that number gets. And that is an interesting justification of taking a statin I had never really ever considered. Would you be concerned about lean mass hyperresponders and their kind of like, I don't know, like not necessarily resistance, but almost like this like air of like celebration that their cholesterol is so high?
Yeah, so it's interesting. There was just a paper in one of the longevity journals. I got it on my phone, but they looked at the laboratory values of centenarians, and they had a great big, I think it was Swedish population, where everybody's in the same EMR, electronic medical record, and they looked at the markers that were of those people. There was like 2 to 3% that made it to over 100, and high cholesterol was one of the outliers. So it may be that higher cholesterol, and this is just total cholesterol, is a predictor. In some ways, it's protective. Now, I would say for those people that are hyper responders, don't so much worry about your total cholesterol or your LDL purely. I like the Feldman ratio. It's the triglycerides over the HDL. you want that to ultimately be one or less. You want an HDL that's higher than your LDL. That's a prediction of very low risk, even with a background of family history, diabetes, hypertension, or smoking, which, you know, some of that is in the past. You can't fix that. But also, I would also say it's not a bad idea to look at, and I'm not a cardiologist, but I just read a lot. Once at some point, get an LP little a, and that's a submarker. It's a little lipo chain that is, I guess, apparently very inflammatory. So when, you know, LDL goes to, to bring healing cholesterol to like endothelial lining, areas of turbulence or break in the lining, this somehow creates inflammation. And the statistic that I have heard is that if you look at those people that die of sudden cardiac death, meaning the first symptom is, they flatline, which is really scary, and I think probably guys like you, Casey, wouldn't have that because you've done a lot of extreme stuff, and if it was going to happen, it would have happened. But anyway, apparently 50% of those have very high LP little A's. LP little A's over 100. And so if you got that, you want to go into like, hyper alert on dealing with it. And statins don't really lower the LP little A. You only have to do it once because it's kind of a genetic thing, that, if you got it, you got it. But some of the newer, PCSK9 inhibitors apparently lower it like 30 to 40%, and other things you can do can lower it. But, heart disease is not something to totally ignore. A lot of lifestyle stuff makes a big difference. Obviously, good muscle mass, good quality muscle, good muscle percent on, on DEXA scans and stuff like that. That all correlates with good outcomes with all four of the chronic common diseases. But within that, if you can optimize that, I think it's not a bad idea to do it. I always remind people, like if I'm going to do a big bike ride, I probably won't take my statin that day. I'll like, take it the next day. And, there's nothing to be said. You can't sort of use it a few days a week. But keep an eye on that ApoB.
Very, very interesting. I really appreciate that very well thought out and thoughtful opinion on that. I guess, yeah, it's so nuanced. And again, in the low carb space, we just poo poo anybody who wants to prescribe statins. And one of the most fascinating sessions at Low Carb Denver this year was the panel of cardiologists. I think Nina Teicholz was on the stage as well, and you've got all of these like amazing cardiologists. Amy Berger came up to me later and said, "We should not have all of these people all on the stage at the same time. Like if the stage collapsed and we lost all of them at the same time, it would be a terrible, terrible loss. They shouldn't be in the same place." But you had two cardiologists that were sitting there, and they were having a heated but respectful discussion. And one was saying you should never, ever, ever prescribe statins, and the other one says, "I work with people, I prescribe it to them, and it does help people." So I don't really know the truth. It's just two different opinions. And we're never going to have like the exact study that says in this exact situation, this is going to be the very best thing. It's just, you got to make judgment calls. So I really appreciate that.
Yeah. And I started off taking 40. Once again, I just started, like at the age of 60, 61. And like, I might be having a little bit of like earlier muscle cramping when I like all of a sudden run up 3 flights of steps to get something, or just things started I noticing a little bit, but I could still go out and do hard stuff. I This year, a group of my high school friends, we did the bike ride across Iowa, which is sort of the RAGBRAI. Yeah, and it was like really hot. It's the end of July. It's always hot, but it was really hot. And we all you know I was taking my statin and had no problem. I mean, I sweated my brains out, but I finished it. And so it's not like there are like a rare patient. And I think at Care Oncology, we had 6 doctors in those days. We had another 5 or 6 over in England. Once a year, within that big, like giant group, somebody would have almost like an allergic reaction where they felt like 3 days into it, they were like a frozen robot with pain everywhere. And of course, you got to pull back. And things that go through my head is if they so borderline in their CoQ10 enzymatic function that like that statin just froze them up, or is it just some serious SNP where they just can't process it well? I don't know, but every once in a while you see that.
Yeah, that's very interesting. That's pretty much like the only thing that I hear is that will happen to pretty much everybody, and it's a huge side effect that most people experience. And I know that's not the case. So again, I really appreciate that opinion. It really shifted my
Yeah,
thinking around
and
that.
we always everything shared decision making. If somebody says it's a non-starter, we're like, okay, I do, they say, can I use like red yeast rice? And then so we don't have any anti-cancer data with that. It does drop, LDL a bit, but and it works, I think, through some of the similar, inhibition of liver enzymes. But so from a cancer standpoint, we just go to other options, and we use a lot of the different statins as well. Like somebody has trouble with a corvastatin, we go to simvastatin and then lovastatin. If they have mainly a liver cancer, we'll probably start with a water soluble statin like pravastatin. So there's some, decision making. And if I'm seeing a 100-pound woman that is, already lost a lot of muscle mass and body mass and is on chemotherapy, I'm going to start at a 10 milligram or 20 milligram dose, not 40 or 80, So everything's customized, and then the liver function test goes into that too. So I guess it's not, willy-nilly how we make decisions
Yeah.
on it. And we try to get people to repeat those safety labs, complete metabolic panel and CBC,
Yep.
look at liver, kidney, basic bone marrow every 2 to 3 months. Most of them are getting it if they're on treatment. And then the pre-cancer patients, we try to repeat the whole panel at like a 3 month and 6 month interval. And, it's people actually like it. I mean, you know, I had a guy who I did the bike ride with. He was much younger and very fit. And he was the first to finish. He's in his early 40s, and he, you know, was always waiting for us at the stop and, at the finish. And anyway, and great guy. And so we started talking as we got to know each other. And he said, I had a big cardiac workout, like a year ago because I got some family history, although I feel great. And, I think I'm bulletproof. And I said, well, if you want to do, I do this panel, and if you're worried about cardiac, then, and I asked them if they did this and they did this and they didn't. And, we did a big panel, and there were some serious signals. And, it's better to hear about it in a discussion rather than hear about it, when you're in the emergency room.
Sure.
So we got on some prevention stuff, but it was kind of surprising to me that he went in and, got a calcium scan and a pulmonary workup and, a lot of stuff done, but he didn't get a LP little a or an ApoB. So,
Interesting.
but that's our system right now. It's still in transition.
Yeah. Wow. Well, this has been an amazing conversation. I just looking at the introduction and seeing all the different things that you're working with on people. It's like you said earlier. To me, it's like a toolbox. There's so many other things that we can use, even just to help things along a little bit. There are lots of low hanging fruit that people probably just don't even know about. Like if you told them to take some fish oil, that they probably just didn't even know. That's very easy to take fish oil. Like there's so many cool things
Yeah,
that you
well,
guys.
there's the researcher Tom Wood, who's a PhD I think he's a neurophysiologist, but he works in sort of the anti-aging of the brain. He calls it, and I love this. He said, homocysteine and fish oils are the unused lottery ticket that sits in everybody's pocket that they never employ,
Wow.
and if he's got pretty good data now from some studies that he has correlated that if you have a homocysteine level over 9 and your fish oil balance, your omega-3 to 6 and 9 balance, isn't in the ideal range, which is, like 1 to 3 or 1 to 4 to 5 or so, they they sampled a bunch of Army recruits, that were apparently looking healthy and qualified to, survive the boot camp of the Army, and their average ratio was 1 to 25. So that's how many, you
Wow.
know, omega nines we're getting through our processing, you know, non-grass fed, non-natural fed animal diet. But anyway, he said, that's the unused lottery ticket. So there's a lot of people walking around, and that's an easy thing to fix.
Yeah.
I use methylated B vitamins that lowered my homocysteine years ago to under 9, and so there's a lot of easy things you can do. Now, I have a part of my webpage, it's called the toolbox, and so you can't spend a lot of time telling people how to fast or how to maintain muscle mass or how to, use ketones. And, I said, I got a 2 to 3 page sort of, attachment I'm going to send in this encrypted email when I send your notes to you. So I do a lot of that. And a lot of that stuff is really simple. It's like, what's the most important thing I've learned in healthcare in the last few years? I hate to say it, it's so simple. It's wake up in the morning, rehydrate, and re-electrify your cell membranes. So a good bolus of water and electrolyte, and it really just turns things on. And that helps you, get rid of the byproducts of metabolism from the night, and kind of resets the charges around the body so you work. Now, you can do that slowly through the day, but why not do it right up front? So I got a whole recipe on doing that stuff, and you know, uh, as you said, some of the things are really simple. It's just that we're not thinking about them, or not doing them, or and so forth. But I
Yeah.
try to emphasize that at Meakin Metabolic. I said I was excited about something coming up. There's a private company out of India that is just brought a what they call blood biopsy. It's a just blood draw where they do 3 tubes and they look at circulating tumor cells. Now, even if you don't have cancer, there's a possibility of, I mean, if you don't have known cancer, we're making foul balls all the time. And usually our immune system figures it out and cleans it up. And as you get older, you're making more foul balls, and you're also probably have a less highly developed immune system to sort of identify those abnormals. And you got other things that are flawed too. So they have a blood test that has been pretty well validated, apparently on like 40,000 people, that has really good stats, specificity and sensitivity on identifying early cancers. And so that might be a breakthrough that will, you know, change the dynamic instead of waiting for physically visible cancers, or a lot of times it's latter stage. They're picking up things early enough to some point where, they actually not only can find the circulating tumor cells, they can identify the source most of the time. So they might say, you have positive signal for, say colorectal cancer. So you then know to go in and get screened and, do a CEA, a tumor marker, or other test to see what's going on. It might be that nothing's found, but you would jump really hard into a prevention program. It might have been like submucosal very early, and that presents a little bit of a discussion point. But uh, I am hoping that we have some sort of better screening tool to find earlier cancers, shortly.
Yeah. Yeah, me too. I've heard that the liquid biopsy thing is not gone as well as we would have hoped, but that there is hope coming up. So that's
Yeah.
amazing. You've already mentioned your website. Your website is very well done, has tons and tons of information. This has been an awesome discussion. I've really, really enjoyed this. Where would you like people to go to find you and connect with you and your work?
Yeah. So uh, if you go to coachitforwardchuck.com, that's my original charity website where I was doing charity coaching, and then I went back to school and started working for Care Oncology, and then morphed into Meakin Metabolic Care. So I have meakinmetaboliccare.com, but both sources have some overlapping information. We do a blog once a month on topics that are interesting to people in the metabolic space. This most recent was sort of a deep dive into vitamin C, high dose vitamin C therapy for cancer patients. Some of what data is there, what are the costs. I had done that like 2 years ago, but we did it again. Um, and then also I send out a twice a month newsletter where I look through the best metabolic magazines, podcasts, journals, websites, and pull 3 articles that I think are relevant.
Cool.
And so that's easy. It's free. All that stuff's free. And so please go to the websites and sign up. We'd appreciate it. And the prevention program for those that are interested might be more your listeners is sort of the what we call the MOP program that incorporates 3 months of supplements, cost of the drugs, the labs. It's a very nice value for, oh my goodness, I think it's like $800. So
Okay.
basically you're getting $1,500 worth of labs, but if you went and paid directly, we can get that for much less, plus the doctor visit, plus the meds. It's usually maybe 2 prescriptions, depending on the person, of course, maybe 3, and then the core 5 supplements. And or if you don't think you want that whole thing, you could just do a doctor visit, or a doctor visit plus the labs. I had one of those today with a cancer patient. So he had done the labs last week, and we added, because he had some unique issues. Like we can add the extra cardiac blood tests, like the ApoB, LPA. We can add the known cancer screening tumor markers if in a woman or a man. We can add a deep dive on the thyroid. We can add, food sensitivity stuff. Try not to get into that until we don't solve it with simple stuff, because deep down I'm a real frugal guy and I don't want to spend your money, and I want to keep the systems low cost, simple, and easy.
Well, that's fantastic. You do such a great job with all of that, and getting that information out is wonderful. One more time, the website is meakinmetaboliccare.com. Is that right?
Yes, and it's MEAKIN metaboliccare.com. And then
Perfect.
the other one is like pay it forward, but it's coachitforwardchuck.com.
Perfect. We'll link both of those in the show notes, Dr. Charles Meakin. This has been an amazing conversation. Thank you so very much for taking the time out of your very busy life to come and educate us about simple and inexpensive ways to help cancer. I don't think anybody out there is not affected by this directly. So thank you so very much for all of your work, and thank you for taking time to be on our show today. We really appreciate you.
Thank you so much, Casey. It's been a pleasure. And Travis Christofferson and I are hoping to be at the Metabolic Conference in Tampa in January. He's
Amazing.
coming to my place in Florida, we hope, and then we're going to drive over. And so if any of you are there, please come up and say hello.
Amazing. We will for sure. Thank you so very much. We really appreciate it.
All right.
And this has been
Stay
another
strong.
episode of Boundless Body Radio.